That's it.
You know, I'll take it.
All right. So, greetings, welcome, and thank you for the invitation to come and speak about our quality agenda for 2020. Dr. Lindsay always asks us if we will kind of reset the landscape every year, and we're always very happy to do it. When Don and I put these presentations together, believe me, we learn to try to put all of it together into something that makes sense. You have to, it's not on one website. So hopefully we'll present information that's helpful to you. Just to tell you from my perspective, EJ is such a special place. And when you look at the outcomes that we have, y'all are driving the highest quality health care of any of the hospitals in the region. We're going to show you some data related to that. But everybody that comes in to survey EJ, they comment on the high quality of care, and even Joint Commission labeled us as a highly reliable organization. To get there takes the work that y'all are doing to drive patient care and safety in the organization. So kudos to you, and it's a privilege to work with each of you. So a little bit about where we're going is, I put this in there because it's really true for the national agenda. It says, "Doctor, can you please prescribe me something for sleepwalking?" And he said, "No, you need exercise." So when you look at what they're doing nationally, it really is around health and prevention instead of just treatment of episodic care anymore. So what do you as a medical staff leader need to know? Well, cost and outcomes is still there. Medicare, as what they're doing with you as physicians and what they're doing with us as hospitals. It's all focused around being efficient and providing care that's got great outcomes, because they say the payers don't want to pay for bad outcomes and low quality care. And I want to talk a little bit and kind of present to you the quadruple aim, which is how all of Medicare's policies are being formed right now. And I don't know how many of you really heard of the quadruple aim. It's IHI platform, but Medicare is using it to drive a lot of the policies and the things that they're expecting us to do as healthcare providers. And focus on the care coordination is rapidly emerging. We've been talking about it for a while, but it is escalated. It is what they're asking you to do. And I'm going to talk about some of the programs that Medicare is paying physicians extra for if they're doing. They're going to continue to do public profiling. So if you think there's any day coming where there's not going to be public profiling, that's not true. They're going to continue to do it. There's too many rating agencies. And, you know, when I look at data, and we do try to provide you with data, and hopefully you get your profile, so we'll talk about that at the end of the presentation. But data is data, and the reason we give you your data is because it can only be close to accurate data if we make sure that things are being recorded correctly. And so when you call and you challenge the data, we like that, because we actually look to see, well, why does it look like that, and why is it assigned that way? Because it's important for you as a provider to know insurance companies are using it, but so is Medicare. And then the other thing is you need to know your data. So hopefully you're taking that, and Donna and I are always happy to pull whatever data you want. So if you want to know what your practice patterns look like, we can certainly provide that to you. So what is the quadruple aim? Well, we focused really on what we call the triple aim for years, and that was outcomes, patient experience, and cost. And, you know, we talk about that, and we focus on that a lot. We focused on that for the last several years, but more recently they added provider experience, and really that was added because of some research that was done with physicians and physician burnout. And I'm sure y'all are well aware of the physician burnout that's going on across the nation. But the triple aim, when it came out, it's not a new approach, but it was really looking at the patient experience. Are they satisfied with the care they're getting? Are we taking the patient's input and including that into the care that we provide? And I know many of you will tell your patients, please go and rate me, because people are looking at those experience ratings when they're choosing physicians too, as well as hospitals. And improving health of populations, that's through our coordination of care and reducing per capita cost. And it's embedded in our value-based purchasing and some of the things Donna's going to talk about, that they're looking at how much it costs per episode of care for a patient, and are we doing that efficiently. But the more recent one is the staff retention and engagement. Yes, it's important on the hospital side, but when you start looking at being able to achieve the triple aim, they finally decided, without including the retention and the satisfaction and reducing burnout of the providers, you can't really produce those other aims. So like I said, this isn't new. It started out in 2008, And then they more recently, in the last couple of years, added the provider experience. So this is just, when you start talking about the staff retention and engagement piece of that, I put this in here because this was in the Annals of Family Medicine, where they did some research on physicians and the burnout that was occurring with physicians. And some of the results was there was a wide gap. It said 46% of U.S. physicians experience symptoms of burnout, and that what they were looking at is they heard physicians saying things like the joy of practicing medicine's gone. I've had physicians tell me that. I hate being a doctor. I can't wait to get out. I can't tell you how defeated I feel. The feeling of being punished for delivering good care is nerve-wracking. No longer a physician, but a data manager. I've talked a little bit about the data. So they published this. Now, they did come up with some solutions for how to do that. We're trying to build on that. I know Paula just walked in, and in our, some of the physician practices, looking at can we do, do we need scribes? Some areas will use scribes, but can we use nursing documentation to pull over into some of the physician's documentation? How can we streamline the things that you're being required to document? Can we pull that data from another source and put it together for you, using our electronic systems to help us instead of hinder us? And so that's some of the work we're trying to do. Trying to do more pre-planning. A lot of physicians I know will say, get your labs and all done before you come, so when they come to see the physician, they have all that pretty much done. So it's just coordinating that a little bit better, standardizing workflows. We work a lot on that in the hospital, co-locate teams for the physicians. So if you have ideas on how we can help support you better, the reason I'm bringing this up is our ability to achieve the triple aims and be the ongoing leader in healthcare is going to require that you feel like you've got the support that you need. So any of us on the leadership team, if there's things that you feel like we could be doing better, we really like that input. We do have some forums where we have physicians who meet with us, like in the surgical area, to say, well, look at this process. It creates work for me, but it's also creating work for you. So when we make the best improvements is when we have suggestions about making it more efficient. And is the work we're doing really necessary, and is it producing or contributing to the outcomes we're trying to achieve? When you look at the state of healthcare, really, that's driving all these things that we have to comply with, they're saying preventable medical errors are the third cause of death in the United States. I guess that depends on the data and how they're classifying that. You can look at that a couple of different ways. The delivery of evidence-based care is highly variable, and estimates of it occurring only 50 to 55% of the time. And poor quality healthcare costs billions of dollars. So, when you want to know what's driving it, and 80% of chronic disease can be prevented with healthy lifestyle behaviors. So when I talked at the first of it about you need the exercise, you need better health, Medicare really is pushing that, as well as the other payers. And if y'all are participating in some of the initiatives with Blue Cross, some of the other things, this is why they're doing it, because they feel like the mismanagement or lack of management or variability in management of chronic diseases is costing them too much money. And depression will be the second most impairing disease worldwide by 2020. Well, it's 2020. And so it's something that we really don't assess as much as we probably should in our settings. But like in oncology, we have put a social worker there. We do depression screening for those patients, and they do get referred and counseled based on their scoring for the depression scales. So, when you look at the healthcare delivery system as a transformation, we're really at the community integrated health level. That was the Medicare innovations and what they were trying to do and support. But I checked off, when you look at population-based and accountable care, we've been talking about that for years. But the population health outcomes and care system integration with community health resources really is where we are, and they're pushing us very hard to coordinate. Many of you may know we are a mandatory comprehensive joint replacement region, simply because our cost was high. And what they expect with that is, optimizing the patient before surgery. Are they ready? Are they well enough for elective surgery? Managing that course of care, and then post-op, are they being put in the least costly level of care for the procedure being done? And they don't want them in rehab anymore. They don't want them in SNF. They really want them coming to outpatient therapy. But our outcomes for orthopedics has grown so exponentially, I would say, over the last 3 to 4 years with the use of robotics, minimally invasive approaches. Patients really are ready to go home very quickly, and they're ready to do outpatient. They don't need those levels of care. So technology is advancing. The care that the providers are providing has advanced, and we really are seeing that. So when I talk about the quadruple aim and why Medicare is doing that, well, here's the 6 goals. And it is reducing harm, patient safety, we talk about outcomes, strengthen person and family engagement as partners. So we talk about patient experience, promote communication, coordination of care, prevention and treatment of chronic disease, work with communities to promote healthy living. So, you know, we do work with a lot of our community partners with services that we don't provide, such as home health and some other things. But they want to make sure that you're choosing those agencies that have high ratings. So like in the orthopedic program, they really don't want you to choose a provider that doesn't have a Medicare 3-star rating, and I'll explain some of that in a minute too. But we really are at the future state where it's people-centered, outcomes-driven, sustainable, and coordinated care. So we're there. I mean, we've been talking about it for years, but it's actually here. So that's why they come up with some of the programs, and I don't know how many of you in your offices, it's really designed around primary care, but CMS pays for one of the transitional care management programs $160, and then if they're seen within 7 days, it's $225 reimbursement. That's pretty good for an office visit to see a patient. They really think that's what's going to drive the outcomes to keep patients out of the hospital, within 7 days. So there are some rules surrounding that, and when you set it up, you have to contact the patient within 2 business days following discharge. So we're really trying to work with, we have employed physicians and we have independent physicians. So are they getting the information that they need if they're not seeing patients in the hospital to make sure they see that patient within 2 days? Contact the patient and then visit with them within 7 to 14 days for face-to-face. So, like I said, when we do these grand rounds, it's really to say, are there opportunities for us to help the physicians in a better way to leverage some of these programs that Medicare has set forth? There's a lot of required elements for it, and we can make this information available to anyone. But they want med reconciliation. It's really not just to say, well, I saw them face to face, but what did you do when you saw them face to face to get that higher reimbursement? There's a 7-day visit, and then there's the 14-day visit, and how those are kind of lined out. And then there's kind of a grid for the straightforward, and then up to the high complexity, where you do, where you would require the possible number of diagnoses to be extensive, amount or complexity of data to be reviewed extensive, and the risk of significant complications, morbidity and mortality to be high. So you can kind of see they structure this in a way that the sickest patients are seen, but they allow you to use mid-levels and other providers to do this. So, if you're going to look at how to maximize your reimbursement in the clinics when they keep reducing reimbursement, there are some strategies out there. And this is just when can you bill? No sooner than 30 days following discharges. And one provider can bill the TCM services only once in a 30-day period. So they're really trying to get these patients managed and seen by their primary care providers in the community. And then what must be documented and in the record to get that reimbursement. And they will audit it. I'll just tell you that. It is a program that's out there, but they will audit it. And I know some places that have been audited, and they look for all those components. Has to be in the record. The other program that they have out there is annual wellness visits. And I think they had one schematic. I didn't necessarily put in here, but I think it's $175 for that. But nurses can do it for the physician's office, so you could actually it doesn't require a physician to do that. And then you can if you do so many visits, the one that showed that if you do so many, it was like an additional $21,000 in revenue just on that model. But it's to keep the patients healthy. And this one's this is annual wellness. This isn't tied to a hospital visit like the previous one was. It's more than just a typical annual wellness visit. And it says it's not the typical hands-on physical exam, but you focus on issues that older adults have. And it's more in-depth, and you get engaged with them on, try to look at emerging risk factors and mitigate those, and review the patient's med list. And I will tell you, this is something that no hospital has really fine-tuned. Trying to coordinate a patient's medication list is one of the most complex things we've ever tried to deal with, and we still struggle with it because these older patients come in with a sack of medications, and the daughter says, well, they don't take this one, and then actually they do take that one, and then when they leave, they didn't bring all the meds, and they didn't know they weren't supposed to take that one. So when we're trying to reconcile medication lists, a lot of times, especially when they're on 15, 16 different meds, it's a nightmare. So it's not as easy as it sounds. But there's requirements such as, and like I said, that's why you can have a nurse, and there's different disciplines that can actually do these visits, because there's different things they're wanting to do. They're wanting to do a home assessment, like fall risk, home safety, hearing impairment. So it's a lot more inclusive than just an annual visit where you're doing the labs and doing a physical exam. And then they want cognitive impairment assessments, screening for alcohol, tobacco, a written screening schedule for checklists for the next 5-10 years. So that's why a lot of people use these other providers to help in the clinic, because it's at least an hour visit usually to do these, if you're going to get into all of these different screenings. So as I talk about all of that out there, so how are we doing? Like I said, we've been focused a lot on the triple aim with outcomes. And value-based purchasing is something that we've talked to y'all about. We're going to refresh your memory about what all is in value-based purchasing and how that is calculated. So Donna's going to kind of take over there, tell you how we're doing. I'm not going to take her thunder, but you're doing extremely well.
Well, that's it in a nutshell. I don't think they need to hear anything else. Y'all doing really well. All right, so value-based purchasing. Who remembers what value-based purchasing is? We've been doing this for about 5 years now. I'm glad that you said yes, Dr. Lindsay. You should definitely say yes. So this is a program that CMS put together that is meant to be budget neutral for them. So, which means they collect this amount of money, and then the top performers get some of the lower people, the lower performers' money, right? And they take money away from these people to give it to here. So for them, they're not taking any money out of the CMS pocket, but this is one of the only incentives that there is. We have 2 others that we'll go over. Those are penalty only, which means we either get it right or they take money away. But this one, if we get it right, we have a chance to make a little money. And as Ruby likes to say, we always like to have somebody else's money, because we need all the money we can get, right? So for every year, these domains change. They change the weights. They change the individual measures that are in here. As I said, I think we're on year 5. This is a 2% penalty, so for us, that's somewhere around 600,000, right?
Between 750 and 800.
Between 750 and 800,000. That's what's on the table for risk for us if they were to take our entire 2% away. But remember, we can also gain up to 2%. So this year, these are the current domains. So we have 4. These used to all be weighted differently, and now they're making it a little simpler for us. But each of these has a 25% weight. And then off to the side, you'll see the different measures that are within that. So for safety, this used to include a few more measures, but now it is solely infection control. And if anybody has been paying attention to CMS at all, infection prevention is high on their list for obvious reasons. So you guys have a big role in this, as Ruby said. This is why we're doing well. We have teams that support all of this, but you guys are either on those teams or act as advisors to those teams, because without your input, we can't make the improvements that we have made. So for instance, coding. We have a nursing protocol that allows us to remove those Foleys when it is no longer justified. That couldn't have happened without the input of the medical staff and MEC to allow that nurse protocol to go forward. We also, and I know you guys, that anybody who's ordering Foleys, y'all are getting questions about, that doesn't meet the justification. Are you sure you still want that? So there's a proactive approach to keep the Foley out to begin with, and then when it is needed, we're working very hard to when don't they need it, and let's get that out as quickly as we can. The longer it stays in, as you guys are well aware, we're setting ourselves and the patient up to have that coffee for that patient. So our surgical site infections, we had a couple of tips up, and some of our colons and abdominal hysterectomies are still publicly reported measures. So anybody that wants to see how EJ's doing compared to anybody else, they can go right on CMS's site and see that. We had a little tick up, but it was through our infection prevention team working with surgery and also working with the surgeons that we now have that under control. And that, we look at what's the standard practice. Are we doing the right thing? This is down to the level of detail. Are we doing the scrub right? Or, what is going on? And when we've looked at every piece of that from an organizational standpoint, and we really don't have any other ideas, then really it's the surgeons are the ones helping us say, well, look, this is an innovative approach we can take. I've saw this new device, or I've seen this new dressing, that, that would prevent that for the future. And we've had great success with that engagement with physicians. The only new measure this year is on the right side of clinical care, and that is the mortality, 30-day mortality for cabbage. All right, and then Ruby mentioned the efficiency measure, which is the cost measure down there. That's Medicare spending per beneficiary. The index date is the admission to the hospital, but the cost goes from 3 days prior, the admission, and then 30 days post. So that's quite a lot for the hospital to have to manage, right? Because we really can't really control what happens before and after the hospital stay. So picking the best home health companies, picking the best post-op care that they can have, that's how we drive that, and care management has a big role in that. All right, so this is just the timelines for this year for that same value-based purchasing. I want to point out to you, though, that the last three are the calendar year of January to December 2020, but the mortality measures and the hip and knee complications span from July 2017 to June 2020. So you might say, well, how in the world are we supposed to fix that, right? So CMS's argument would be, we want to make sure we're looking at statistically valid data. So that's why we want to have a good 3-year run for your mortality. However, for us, right, if we didn't manage it in 2017, we would have to wait a couple of years for our bad data to fall off in order for us to look good. So this looks good because we have been working this and continue to work it every month, every year. We look at this data, we drill down, we get people involved, we ask you guys questions. And I don't know where that slide is with the OE, but we'll talk about what you can do, because there's the actual stuff that happens, and then there's the documentation of that patient's criticality. And so that's your expected. So this is a timeline. We couldn't find the most recent one, but this is how value-based purchasing has gone along. There's been lots of iterations